We've talked a lot about medicine and data moving into the cloud, but in fact, for the foreseeable future, we'll also need bricks and mortar hospitals. Here in the Mount Sinai Health System, we have a unique opportunity. Dr. Davis and the hospital leadership have committed to building a new hospital at the Mount Sinai Beth Israel site. And so we have a fantastic panel that's been put together by Kumar Chatani, who will be chairing it, Chief Information Officer, as well as Rama Iyengar. And Kumar, if I can ask you to come up and introduce your panel members about the digital hospital of tomorrow, of the future.
So good morning, everyone. I'll invite my panelists to come up on the stage. Yes, all there's its names in the front. Good morning, everyone. And I'm Kumar Chatani, Chief Information Officer for Mount Sinai Health System. And I love the conversation the previous panel had. And Praveen Nath was channeling all my thoughts. I mean, he was relating what a CIO has to think about when you are dealing with startups. Because we have a complex ecosystem. We have to run multiple hospitals. We are stewards of the data that the patients have entrusted to us. And there are a lot of complex factors that come into play. And when you have the startups coming in and giving you a pinprick solution, there's a whole ecosystem that can get damaged, and you could have consequences down the road. So we have to really think hard about how we allow the startups to come and help us, support us, grow us, as well as the risk of polluting our ecosystem. So these things have to stand the test of reality. And our systems and our operations have to be fluid to support our patient. So we're going to talk about how this reality happens. We're going to talk about what the hospital of the future will look like. How do we take some of these ideas that we learned about in the last couple of days, and I'm very excited about all the things I heard. How do you convert that into reality? And we have a group of experienced practitioners who have background in planning, design, architecture, running hospitals, technology consulting. They bring a wide variety of thoughts here. So I'm going to introduce a few of them quickly, and you can look at their bios later on. But Jeffrey Brand is the healthcare leader for Perkins, Eastman Architects, and you can see some of his work, if I can get a chance to click this. At Memorial Sloan Kettering. Next is Barbara Collins. Barbara Collins is the Chief Operating Officer at Humber River Hospital in Toronto. And we are so glad to have her here. They just opened the hospital this month. And you can imagine how busy they must be, but they still took the time to come here. So thank you for that. And they're going to tell us all about their experience and what they're doing about patient experience and what they're designing into the system. Rueben Devlin is the Chief Executive Officer and President of the Humber River Hospital in Toronto. And Rueben, thank you for taking the time to come here. I know there are a lot of priorities back home. Mark Gilbert is the Senior Director and Global Design Lead at Gartner Consulting. It's one of the leading technology consulting companies in the world. Laurel Harrison, Laurel Harrison. She is the Health and Wellness Sector Leader and Senior Principal at Stantec. And Laurel was involved in the UCSF's Mission Bay Hospital, and she is also working at another master plan in Doha, Qatar. She's going to tell us about that also. Thomas Quigley is the Senior Principal and Director of Healthcare at HOK. It's one of the largest healthcare design practices in the world. So all these leaders have practical experience. They live it, they have seen it, they are envisioning the future, and they are going to adapt, and they're going to be flexible because the future is going to change. All of you saw the the film from Kaiser Permanente 30 years ago, right? And I used to work for Kaiser. And things have changed. Now, what will people say about us 30 years from now? So we have to start designing the hospital of the future with that in mind. And then there is a QR code somewhere all of you may have, so you can send us questions. So this is a really complex topic, so we said we're going to focus on 3 key questions. The first question is, how will the patient experience be different in the hospital of the future? The second question we are trying to answer is, what, from the perspective of architecture, what are the architectural design and planning considerations? Because you got to build a lot of flexibility into your hospital facility design because you're looking at what will happen 20, 30 years from now. And how will technology adapt around that? The last piece is, how will technology be different? And Mark has a lot of controversial ideas. I'd like to hear those. And some of those ideas may disturb you. So without much ado, let's start with patient experience first. And Rueben and Barbara, you can jump in. Tell us about what you were thinking as you designed your new hospital. What were you thinking about the patient experience? How is it going to be different? And what have you built into your system?
Thanks very much. And it was about the patient because frequently hospitals of the past were built around the providers. And we spent a long time discussing what was important to the community and to our patients. And in the last panel, they said, what were the criteria? And we set down some criteria of quality, safety, efficiency, and customer service. And as we went through the process, if it didn't fit into those buckets, then it wasn't going to happen. And it was also assessed against the business case to ensure that we were on the right track. The other thing, as you saw on one of the slides, is that we developed principles for our project being lean, green, and digital. Lean being efficient, green being friendly to the environment, and digital, that we're talking about now. But I think the first point I'd make is that this is not a digital exercise. This is an exercise in process redesign, and that it's all about patients, the patient and families, and so that we needed to look at different processes within our hospital that could be improved against our criteria that would make it better for patient care, but also for their experience. As you saw on one of the slides, one of them was patient empowerment, and that it was important that patients were partners in the care as opposed to recipients just of the care. And so a lot of the things that we put into the hospital that's now open 10 days met those criteria.
And Barbara, you as a chief operating officer must be worrying about this in a different manner.
Just worrying a little bit, yes. Patient-centered care, I think, for us was really focusing on the patient experience. Patient empowerment, some of what we've talked about for the last day and a half, but their real participation in their care, and that means communicating with them. But there's 2 key elements for patient-centered care to really succeed. And one of those is that the resources of the organization can be focused on patient care, that staff and physicians and people looking after patients are not frustrated in their work environment, and they're able to access the resources they need. So, in fact, the lean element of our vision was exactly that. And some people talked earlier about, what's the payoff for doing this? The payoff is always if you can turn the resources back into patient care, and I think that was a driving force for us. It allows the patient more time with the providers. It allows the patient to have their questions asked. And one of the key elements we did beside process redesign was use digital technology to improve communication. Every time you have a patient care problem or you look back on a quality of care issue, it most often is as a result of poor communication. And so one of the things we wanted to do was to allow the providers to communicate better and the patients to communicate better with each other, and that was one of the driving forces behind it.
Did you use any particular technology to improve the patient communication?
Yeah, a number of elements. First of all, we developed an integrated bedside terminal, which is a device that the patient has available to them, both to have their health record, so they have access to their health record. They can video conference with their patient care providers. So, in fact, the call bell goes off. It's not kind of the voice of God from behind the patient. It's actually a video conference direct to a handheld device that we created, we worked on. And so they're actually able to communicate face-to-face. It allows the patient, patients will always go to Google and look up any blood result they see, anything they see abnormal. We've actually provided those resources on this device and geared them to those slideshows and those videos we would like them to watch, but allowing people to do that. They can Skype with their family, do a number of different things on this device, communicate with hospital staff, things like that. So it just gives them that power at the bedside. We've created a patient portal, which, of course, once they're out of the hospital, allows them access back into their record. They can pre-register, determine what the emergency department wait times are. So a number of devices like that.
Jeffrey, you had a comment?
Right. So I think we're seeing an awful lot of ambulatory work in our client practice, and our clients are asking us to solve some of these problems digitally. So what we're seeing are things like geofencing, where you come into a building and your iPhone identifies you to the facility. And why is this important? It's important, number one, a lot of patients arrive early because they're nervous about missing an appointment, so they want to be there. And it gives you opportunities to engage with the building more. If you're a chronic patient, let's say you're a cancer patient, or you're going to a medical office building and you're going there week after week, these things can become very boring to you. So the ability to push information out at you and say, hey Jeff, you're here early. There's a yoga class going on over there, or there's a special guest chef today, or there's a class exactly in changing your catheter. Why don't you go there? So pushing information out, whether it's experiential because they're positive things, or they're clinically driven, is very, very important, I think. And geofencing isn't quite there yet, but I think in the next couple of years it may actually get quite sophisticated.
Okay. Thomas and Laurel, any thoughts?
I think the whole patient experience question is one that we'll continue to wrestle with as the boundaries of care and if the buildings get softer and softer. The experience starts at home, it finishes at home. The hospital is an interlude, a portion along the way. So defining that experience and making it cohesive from the virtual to the built environment through the care environment is an ongoing challenge. And responding to the drivers, responding to what makes patients feel comfortable, what makes providers feel comfortable, and perceptions of quality as they evolve through this digital evolution will change the way I think we frame that experience within buildings and the emphasis that we place on the things that we have been doing for the past sort of 15 to 30 years and looking forward in that same duration. I think we'll be making different choices and reevaluating what experience is and how much of it is purely what you walk in the door and see versus the entirety of that experience and how all those pieces come together.
Thomas?
And I think that the user experience is one that we're really starting to wrestle with now. We've spent a lot of our history, and we'll speak about that here in a moment, we spent a lot of our history really dealing with the process of care delivery, and now some of these technologies are actually affording us the opportunity to free ourselves from some of those constraints and really think about what it's like to be a patient or a provider in this environment. And I also think that there's a tremendous opportunity to humanize sort of the act of healthcare. Mm-hmm. And when I say that, one of the projects we've most recently done is we've used this sort of geofencing technology so that when pediatric patients come into a facility that it identifies that they're there, it gives them an avatar that follows them and tracks them throughout their experience within the hospital. So if they're in a waiting room, their avatar will pop up in a particular place, and so that some of these comforting mechanisms can really play an important role in the care delivery process.
And Mark, you have been studying a lot about technology in this space. What do your tea leaves tell you?
Well, first off, we've observed the power of focusing on patient experience and the impact that that's had on patients and the outcomes. But I'd like to broaden the discussion a little bit in that, you're a patient for such a short period of your life. And really you're a customer of a health system. And I think we need to broaden the perspective of experience to look at that customer experience and say, what's my experience beyond the boundaries of the healthcare system, as well as what's my experience from a health perspective? How well is this contributing to my overall health? The second thing that I'd like to observe is that we should also look beyond just that customer and look at the physicians and look at the extended care teams that are part of a patient's support system and their experience as they go through the process, and making sure that the physicians are indeed having a good experience giving care to this particular patient, as well as the extended care team.
Go ahead, Rueben.
Yeah, so I agree with a lot of what you said. So we looked at the continuum of care, and it was important for us to say, we're an acute care hospital, but the care that you receive at our facility is episodic, and it has to be part of the continuum of care, and that information has to be shared with our healthcare partners. The other point, which I think is critical, is that the patient experience is directly related to the staff and physician experience. And if you create a work environment where staff and physicians feel satisfied in their work, then you're along the route to being successful. So much of what we did was to try and automate the processes to allow our staff and physicians to spend more time with the patients. So no more writing on the, so our medication process completely automated, so there's no writing, as opposed to it's directly downloaded into the EMR. The process of lab work, the same thing, and then the physicians will not have to seek out that medication. There's push technology to allow them to receive abnormal results. So much of what we did was to try and make it a better workplace, and therefore the providers are now spending more time with patients, and therefore improving the patient experience.
Did you introduce any technologies to facilitate that, Barbara?
Yeah, there are a number of things. First of all, with the handheld device that we've worked on with Avaya, in fact, we can have rhythm strips, abnormal lab results, any kind of technology pushed out. So our intensivists in the intensive care unit, for the patients they're concerned about, or an abnormal ECG rhythm anywhere they are, will pop up on the screen and let them know there's a problem. There's an opportunity to communicate directly with the nurse while you're looking at the rhythm strip, a face-to-face with the nurse to communicate on what's going on, or a visual for the patient. As a matter of fact, there's a camera in the patient room, and you can actually see what's happening with the patient. We've also used that in our operating rooms and our interventional suites, where in fact there can be an opportunity to communicate with anyone, anywhere else around that procedure or any problems that you're running into. So in fact, through an OR suite system, you're able to communicate with another physician who can either see what's going on in the room, see what's going on at the end of the endoscope, or see what's happening in the surgical field. There are 3 ways of visualizing what's happening, also to share the pathology or the diagnostic imaging views, but it allows real communication, real-time communication, and real-time consultation. And so we've installed that in the operating rooms, in our interventional suites, and our trauma rooms. And it does bring some level of opportunity for our physicians to communicate with others.
And does it also give them the ability to do remote consultation if they need it?
Yes, they will be able to.
Rueben?
So each of our nurses, as I said, has a handheld device, and when the nurse call button is what we have the conventional due to code, but on the bedside terminal there's a button, and when you press that, you connect directly with your nurse. So the system knows who your nurse is for the day. So it's not going through the system; it's going direct to the nurse, and we believe that's going to expedite the care. It's going to improve the patient experience, because that's the big complaint. I pressed the button, I didn't hear back for a long time. This way, it's immediate response and connectivity. And connectivity, as we have hospitalists, connectivity to the hospitalist directly as well, to ask about the questions, or a family member's there that wants to know about the care.
So go ahead, Laura.
I was going to say, I think for us that both the challenge and the success in what Rueben and Barbara are talking about is that these are projects that started, being discussed 10 years ago, and we're delivering current technology in them, even though the project started, in construction 5 years ago. And they are current today, but they have to remain current. And so just the challenge of getting to this point, much less maintaining that accuracy and currency in the conversation for the foreseeable future when we don't actually know what that future is. We spent the past 24 hours talking about the pace of change and being dynamic and responsive, and that's a very challenging thing in the bricks and mortar world. And so we're having to really reconceive the conversations around flexibility. I think we all, as facility providers, understand what baseline flexibility is, how to make a building that has the capacity and structural integrity to last 50 to 60 years. But how to make a building that can evolve and respond at the pace of change that we've been discussing for the past 24 hours is a whole other challenge. And to do that, create that flexibility and responsiveness in an environment that still feels at minimum familiar and ideally comfortable to the patients and their families is a huge challenge. And I think it'll be very, very interesting to see how that evolves in the next few years.
So
Rueben, go ahead.
some of the technology that we blue skied 10 years ago actually didn't exist.
Yeah.
And so we're fortunate that it does exist now.
Some of
And-
these things exist because you blue sky them, because you partner up with people.
And to the other point is that we are setting up now our digital center of excellence so that it's not the digital hospital of 2015, it'll be the digital hospital of 2020, 25, and are going to work with vendors on what would be in the future, and work, more important, I think, with our providers to ask them, what more do you need to provide better care? And I know that so the companies that want to have that kind of working relationship with our digital center of excellence in order to improve the care that we provide.
I will also say that.
Go ahead.
Oh,
Go ahead.
that the hospital of the future is not just the building that we're in, but it's also your home. And a lot of patients are getting released, and they're untethered and they're terrified. So the ability to, at 3 o'clock in the morning, have them go online and reach out to their caregiver and say, hey, this catheter is giving me a problem, or I'm really scared, and have that connection so they're not just adrift is really important. And the market is very savvy. People are really understanding. They can go on their iPhone and they have choices where to get care. So the more you can do to help people realize we are here shoulder to shoulder with you, and the technology is there. When you go home and you speak Chinese, we'll give you this video online that you can talk about this, or you're Ecuadorian or some other culture. You are reaching out in the best possible way, and that's what the digital world is going to do. It's going to connect you in a very robust manner, and people understand that, especially this next generation are very savvy with their iPhones and how to get health care, and you can't underestimate the ability for people to do their own research and feel connected.
So let's switch gears a little bit here. We're going to switch to architecture and design and planning of the hospital. And all of you have been involved in a lot of constructions, and you're designing some facilities right now. So I'll start with Thomas, and we'll go to Laurel, and then we'll go to Jeffrey. And you can tell us about what facilities you have worked on, what is your view of what is coming down the road, and what are you building right now. Let's start with Thomas.
Sure. So maybe a little bit of a historical perspective might be of value. I think from the healthcare architecture standpoint, for the last 50 or 60 years, we really have viewed ourselves as contributing directly to the care of patients through the design of a machine for care delivery. And I think we worked very, very hard in collaboration with you all to create an environment that supported a very specific series of processes, or answered very discrete questions, whether they were micro or macro in level. And I think we had a lot of success. And I was sort of struck by Dr. Kraft's video yesterday of the Kaiser Hospital of the future. And I'm not sure sometimes what the problem was we were solving. I was thinking about the postpartum bed where the new mother gets to ring a bell, and they put the baby in this thing that looks sort of like a file cabinet, and she opens it up on the other side and pulls the baby out. But I think in some ways it's illustrative of the kinds of questions we've sought as we've worked with our clients, trying to say what are the things that we can do from a facility and a spatial standpoint that facilitate your process and facilitate your care delivery. And we've built numerous mock-ups and gotten all the medical gases and all the outlets just so. And, you know, in our practice, we've worked with a lot of clients, and many of our clients build $500 million, billion-dollar assets, and these assets are intended to last for 50 years. And you know, and not only that, they were in a pretty limited number of venues. You know, we were maybe doing some acute care hospitals, maybe a little bit of skilled nursing. But, you know, in the early years, there wasn't a whole lot even in the ambulatory space. And then, you know, the 2 or 3 venues became 5 or 6 venues, and now there's 20 venues that we are looking at, and many of them have no spatial implications, as Jeff has suggested. And in those instances, it's wearables, it's virtual consultation, it's retail, and so that's changed the dynamic that we exist in. And one of the things that I think that we have found as we're building these $500 million and billion-dollar assets is that, as has been alluded to by Laurel, you know, we have 5 and 10-year delivery time frames, or 20-year delivery time frames, from the glimmer of an eye to, you know, to the day that you're seeing a patient. And I think we've observed that the technology evolution cycle is so much faster than that. You know, you've got technological evolution in 3 years, and so in the 10 years it takes you to conceive and build a facility, you know, you might have been through 2 or 3 iterations of evolution in care, and how do we support that? And so I think the argument that we would make within our practice, and I'm sure my colleagues would say the same thing, is that it's probably time to begin to decouple the notion of facility, you know, exclusively driving process or being the main contributor to process, but being more, you know, about creating a plug-and-play environment for care to occur, creating structural systems and mechanical systems that allow whatever the most current operational modality is for it to plug and play into these new buildings. So that sets a whole new paradigm for us to operate under. And one of my colleagues refers to it as precision medicine loose fit. So how do we create that building that is a 50-year billion-dollar asset, but allows itself to be regenerated over its life cycle? And, you know, the way we're watching technology, I mean, it could, you know, it could regenerate itself 10 or 15 times over that life cycle. So,
Laura?
Yeah, I think to extend that thought, the machine that we're imagining now is less customized and tailored to how you do things today, because that's going to change tomorrow. I think we're trying to conceive of things, as Thomas said, much more plug and play, much more the way that we think of the iOS platform, a framework, a stable base from which you can create all the things that you need to do and be able to adapt and respond in a much more rapid and evolved way, because it's frustrating. We're all very aware of the things that are happening, but it's frustrating to get to day one, opening a project, and know that you're already encumbered with some obsolescence and some things that you wish you'd done differently if you just knew what you couldn't possibly have known 5 to 10 years ago. So we have to really wipe the slate clean in some ways and reconceive how we create these environments and allow them to adapt around us. And I think the challenge in that alludes to something Thomas mentioned earlier about maintaining the humanity. It's maintaining people's sense of the familiar, how to adapt continuously around everyone, and yet let providers and patients understand that this is okay, that everything hasn't changed. The fundamentals of care, the fundamentals of the patient-provider relationships are all still at the heart of what we're doing. We're just trying to do it better, more efficiently, more effectively. To do those things without taking away everything that's familiar, I think, is the challenge for us. And to create that adaptability in a very different way that's not about, you know, as we talked about a 10-year or 15, 20-year life cycle change, but it's a 1-year change. It's taking something today and being able to literally move it from one side of the room to the other tomorrow so that you can deliver care more effectively on a day-to-day basis, being very responsive to what the lessons we're learning.
Jeff?
So I would build on that as well. I think it's, you have to, we're really in an age of exploration. You really have to take the can you do this attitude, and we don't even know what the this is at this point, because a lot of the research and what the medical staff are telling us to do is we're going to want these future modalities that could be mixing an MRI and a LINAC or a PET and an MRI. And so how do you plan for that in the future when these things become more robust? So I think we have to create a clinical infrastructure and armature that is really expansive to allow for anything to get plugged in, as Tom has said. But at the same time, the money is staggering. A lot of these IT costs are staggering. And the buildings that we're working on are very, very smart buildings, even when it comes to controlling the environment on the outside and climatization and sun loading, staggering amount of money. So how do you balance that is, I think, part of the problem, and how do maybe you add things over time. I think in some of the smart buildings that we're doing, especially ambulatory, they're dripping with technology. There's just so much in there. I think the buildings are going to truly vibrate when they open online. But I think what scares me a little bit is the sense of the marketplace. I think for the staff stakeholders and the patients, they want to see a warmer human side. So I don't want to lose track of the fact that technology can help us and IT can help us, but people are quite scared of some of these things. And so the armature needs to be clinical and robust in IT, but I suggest that the front pieces that are more hospitality-like and warm and talk to the human spirit on us is very, very important. And that's where the experience matters about how you try and live your life normally, and you're coming into a building and you engage with it, and you can find socialization or quiet places or a business center, and also get fantastic care. So for me, the hospital of the future and the teams I work with and the clients, they're looking for a village that is much more complex. It really mimics real life in a way. And so you have to take what you're really seeking as a stakeholder and find it in that building. If you are a staff member, a physician, and you're wrapping a medical team around you, when you go into that building on Tuesday, what do you need to do your job? And that's what people are seeking. And I think that's how technology helps you, because you can pull up anything anywhere. And that truly is the connectivity that we talked about this last night, and how you plug in and get information. Really, really important. But it costs a lot of money.
So Rueben and Barbara, when you design your hospital, what were the considerations you had for architecture? I know you talked about flexible design, and what will you do when the technology suddenly changes 20 years from now? How will your facility adapt?
So before I answer your question, I'm going to make a comment on, one of the speakers mentioned this term yesterday. It's something we've spoken about as well, as the industrialization of healthcare. And so you're not designing an office building, you're designing a process where people do their work. And so that drove, when we, and Barb did a project on sneaker time, and she might talk about that, about measuring how our nurses' workload was, and how was design and technology going to change some of that, so that experience happened. So maybe you want to.
I will speak a little bit about that. I think, Jeffrey, you addressed the fact that there has to be the human side, and I think everything we've done is to try to decrease the frustration, and I'm looking for a chart, I'm trying to find info, there's a mixed communication, and turn that to a much smoother process, and then allow the clinicians, nurses, physicians, physios, whoever, spend the time with the patient as opposed to spend the time with the paper. And I think that's really the important key part of it. And regardless of whether you're for-profit or not-for-profit, I think it's always about, there's never enough money to do everything you want. And so the patient care side of it really does need to be a focus if you can get people back there. In terms of the discussion, and I'll speak to that just very briefly, we did do a very detailed following our staff around for a 6-week period of time to really see the kinds of things they did. And it very much surprised our staff and physicians, not when we sat them in a room and said, what do you do to deliver your care, but we actually followed them around and said, did you know you did this? And then with the help of one of our vendors, we created a parabolic model and loaded in a year's worth of activity. And so it directly showed, for example, on a medical floor, a nurse walks 5.4 kilometers a day in an 8-hour period to deliver care. If all we did was build a bigger modern facility, she'd have walked 11.6 kilometers in a day. Never would have seen the patient, never would have had that face-to-face communication. And so we began to brainstorm with the care providers on what things would make you do this less. Watch the model. Look how often you went here, you went there, you did this. And that's really where some of our digital items came from. So it was really down to what's going to prevent you from having to do that. And I think that worked. In terms of the cost of technology, just very briefly, we took the risk of partnering with a vendor for most of our high-tech, mostly diagnostic imaging, but most of our high-tech equipment for a 15-year period. So we actually went into what we called a managed equipment services agreement with one vendor, went out to RFP and selected that person with the requirement on their part that they be at the table during our design process, which takes 5, 10, 15 years, and actually tell us not what's available now, but what they are working on, so that you can design for that, what they're working on. And we have now a 15-year life cycle plan for replacement of most of our major equipment. There's flexibility in it, in that if the PET scanner changes more than the MRI and you want to move something around, you can. But it gets that person, that group to the table and that commitment for a 15-year period to be a real partner at the table, to help with the technology, to help with the interoperability and the integration, and then to help you really design for that future flexibility for the hospital.
So let's move to technology. For those of you who don't know Gartner Consulting, it's a leading firm in the world, and I've used them for over 20 years, and they have deep knowledge in technology, and they look out 10, 20 years ahead, and Mark has been partnering with us in some of our digital medicine efforts here. So Mark, you have been studying this a lot, and you have been pretty provocative about the very need for hospitals and how the hospital footprint has to shrink and why. And you have talked about how things have to move outside the hospital into people's homes and all that. Can you tell us about what you think should we be thinking about in terms of technology of the future for the hospitals, and where do you see this whole thing shifting?
Well, thank you. I think certainly not a brief conversation. I agree and I empathize with a lot of the points that are brought up with regards to having flexibility and having a long-term vision on the facility, et cetera. But I would suggest that we're going through a period of disruptive change as a result of digital technologies. And I would suggest that we take a step back and really question the need for a hospital and what's the hospital's role in the care delivery of the future. And I would suggest that it's going to change. It's going to change dramatically, such that really what's the best hospital? It's really one without four walls. It's a virtual care delivery system that's capable of providing the right care at the right place at the right time, and does so with the optimal outcomes and in the lowest cost settings. And typically that's not inside of a hospital. Hospitals are generally speaking the most expensive square footage property that you could build. So is that the right spot to deliver care? Generally speaking, if it is an emergency or an illness or injury, yes, but for that 99.999% of the time of the rest of our life, it's not the right setting, and we need to be able to provide care outside of that setting. So as we look at specifically hospitals, we suggest and highly recommend, first off, recognize the disruptive technology. The pace of change is so dramatic, so quick that you're not going to be able to get on the front end of this. You'll always be adapting as you evolve. So certainly having flexibility is important, but when we look at the hospital, let's look at what's its role in the future. And that, I would suggest, is not necessarily one of being all things to all people, but a purpose-built institution, one that achieves the fundamental goals of what I believe, what Gartner believes is important is, collaboration and communications. Is it, in the past we built a hospital so that we could bring specialists in, so that we could bring patients in, so that we could collaborate and observe this particular patient and treat this particular patient. In the future with, digital tools, we don't necessarily need to bring that person in. We don't necessarily need to bring specialists in and others into that particular environment. So can we create an innovative communications and collaborations environment that allows us to extend care beyond the boundaries of the hospital? So that's a great item to put on your task as far as a functional requirement. Is it facilitating innovation with communications and collaborations and allowing me to do so virtually across the continuum of care? The second thing I would suggest is that we're at the hockey stick of innovation in care delivery and how we do things and the impact and the outcomes that we're going to have. So a hospital becomes a great environment for purpose-built innovation centers. How do we innovate? Can we monitor how we do so? Can everything be the equivalent of a clinical trial within our environment? As we get to precision medicine, personalized medicine, it's going to be essential that we have the rigors around innovation and embedded inside of our facility the ability to innovate in order to be able to adapt and change things. So as we look at a hospital, it's extremely important. Communications, collaborations, innovation, be able to adapt and trial disruptive technologies, and to be able to measure the outcomes on an individual and adapt and evolve quickly.
So yes, so I think that's really a good point. So I think the non-hospital is also really important, and by that I mean, can't we use digital technology to help population health and prevent illness and use wellness and prevention as a tool? Because I think that's what a lot of hospitals are doing now. They have call centers, which is a very low-tech, actually, type of building, but you're calling your patients and saying, you know, your blood work doesn't look so great, you're diabetic, let's look at your nutrition. So I think there's a lot of things we can do to make the hospitals potentially smaller and have home health improve, and that's all technology-driven and advisors, medical advisors. So I think the world of the hospital is everywhere. It's not just in the building. There'll always be a hospital, but we have to, I think, work to minimize who's really there.
Right.
So,
Go ahead, Rueben.
so although you don't want a hospital, we agree with you in the sense that we recognize the fact that you only come to the hospital episodically for the most acute care. And one of the things that we also recognize, and everybody's different. Everybody, as you're designing things, your patients are very different. Some of them have the same family physician for 35 years. Some of them come to the hospital or seek medical attention like they go to McDonald's. They're sick now, and they'll go see anybody. And so we see ourselves as well as the keeper of the health record. So if you have a patient portal and you go to a primary care physician who's never seen you before, that physician can now access that health record. They don't have to be coming to us, but we can be the guardian of the record for them as they access it. And so that, yes, we agree that more and more healthcare, because of technology, can be out in the community, or if they come in, you know, when I got my medical degree in the dark and Middle Ages, when somebody had an MI, they'd be in the hospital for 2 weeks. You know, that was, and they couldn't move. Now everybody, the treatment in a very short time has been revolutionized, and because of technology and the less interventional surgery, minimally invasive surgery, which we focus on, critically important to better care. So we support the concept of care out in the community, but we also support that connecting the continuum of care so that information is transferred back and forth between primary care providers and acute care facilities.
Thomas?
So, you know, I actually agree a lot with what's been said, and you know, and I think Mark, in maybe some ways, thinks he's throwing stones. That we're in the building business. You know, we want to see spatial sort of manifestations of ideas, but I think in large measure we agree, and I even think about some of the clients we've worked with over the last 10 years and recognizing that this sort of dissolving or decoupling needed to happen, and not even being able to find the right mix of consultants and expertise to have a fully informed discussion about how do we really decouple and how do we distribute across a whole series of venues, and what is the essence of the hospital. I think there's also another thing that we're doing, and that is we're calling something a hospital, and we're using that as a very generic term that stands for a whole series of different kinds of places. And you know, we work with a whole lot of different hospitals. Some of them are community hospitals, a lot of them are academic medical centers, and the role that they serve not only in care delivery, but in innovation and teaching and so forth, are vastly different. And I think about some of the struggles that we are talking with some of our academic medical center clients, where you know, they're talking about a hospital as a part of an integrated activity that is about learning, that is about research, that is about clinical care and teaching. And at some point, while in maybe some settings, some of these things become much more diffuse. In other instances, I think they actually have to be considered in a way that might be more integrative and more, to Mark's point, collaborative as a vessel or a basis for collaboration and not necessarily complete diffusion. So,
right. So we have about 10 minutes left, and there are a lot of questions that have come in. So I'm just going to see if we can answer a couple of them at least. This one is probably most interesting to me. I'm going to give this to Barbara. It says, how does the partnership between IT and operations evolve with the rapid pace of technology? Is it IT or the medical departments that drive technology innovation in the hospital? What makes this bridge effective? So how do you see the partnership working? Where does innovation come from? And how does it become effective in a hospital setting?
Okay. So I would say that it can't be either one or the other. It has to be them together. We've actually put our users and our IT groups together to resolve issues and problems. So we did the lean exercise, the visioning of this would make my life easier, and then working with the IT department, we challenged that some of those things needed to be resolved. And you need to keep those teams working hand in hand. And I think the Digital Center of Excellence that we talked about is really an environment where there's a think tank and to try to keep making the change. So here's my problem, how can we help? It may be the vendors, it may be the IT department, it may be a particular startup group, it may be anybody who comes together and helps the clinicians try to resolve the issue they have. You have to have a fairly, maybe a flat organization, or at least an organization that's well integrated, and people are able to talk to each other. And I think you have to have a significant commitment from the entire organization about creating this vision and driving it forward.
Great. So the next question, thank you, Barbara. Next question is for Rueben. It's about defensive medicine. It's pretty interesting. It says, will increased patient empowerment to accessing the record or bedside Googling treatment options lead to an increase in the practice of defensive medicine that may increase unnecessary costs?
So I think the answer is absolutely the opposite, is that an empowered patient understands their problem. We've heard some interesting concepts of how they can track their own health care. They want to be engaged in it. So and then the discussion with the person, with the provider that's providing the care, and that for that specific illness, will then have the conversation about how they can prevent it in the future. So I think that that the informed patient is a benefit to the whole system. We actually the patients who have piloted in the past find it better. They understand. We get, we do from time to time get complaints, but we don't get complaints from them because it's the communication part that is critical to what happens, and then the preventive part flows from that, which we think obviously is critical to the good health of the patient.
So we'll take one more question. It's maybe someone from the architecture firm can answer it. What physical, structural, and design methods would you employ to best future-proof the digital hospital of tomorrow? So it again goes back to flexibility that we have talked about. So maybe Laurel or Thomas or Jeff can comment on that.
Maybe I'll just start for a second. So I think you have to sacrifice a part of the building that becomes this high-tech zone. So as an example, we're working on a LINAC MRI. It's about the size of this room, at least, probably. So you have to imagine that some parts of the building will always need the plug and play that Thomas talked about. And you prepare that, and you say, okay, so the floor is heavier, potentially, and maybe there's some structural top coat that I can put wires in and cables. And so you anticipate that. The whole building does not have to be future-proof, but some part of it. That's what I would add.
I think that there's some mechanisms that we've started to use. I mean, we look at structural grids, and we know that if we have a structural grid that's somewhere between 30 by 30 or 32 by 32, that we can put a whole lot of different kinds of things into that structural bay. We can put pretty much any kind of, there are some sort of more robust diagnostic and treatment modalities, but generally speaking, we can put most sort of procedural platforms and diagnostic platforms in, something that's 800 square feet. We know that in a 30 by 30 module, we can put 2 patient rooms. We know that in a 30 by 30 module, we can put some sort of officing collaborative space. And so sometimes it's about, what are the bones of the structure like that allow for you to put these different kinds of spaces in. Sometimes it becomes about an exoskeleton, thinking about how you distribute mechanical, electrical, plumbing systems external to the footprint of a building so that you're serving it from the outside in, and you can more readily move things around, the rigidity and vibration resistance of the structure. And so those are all many of the kinds of tools that we're thinking about in using to try to give these buildings flexibility. I think we typically use really, diagnostic and treatment platforms that are highly integrated, so you're consolidating all those activities in one place that has this ever-evolving sort of lifespans. Laurel?
I agree. I mean, I think you'd find a pretty stunning constancy across the various design firms that those are pretty much the basic tools. But for me, it's not so much a specific solution as really framing and understanding the conversations about flexibility. What does that mean to your organization? What are you seeking? Are you really seeking something that has this 50-year life cycle that you can go in and gut the space and do major reconstruction and respond in that way? Or are you seeking day-to-day adaptability? And what's your organizational tolerance for that kind of change? Some organizations, some regulatory environments don't really allow for day-to-day change, and we struggle with that in the built environment as much as you do in the care delivery environment. So I think really getting at the priorities and the individual organization's understanding of those priorities, how they move and evolve as an organization, how they make decisions, the timeline, the consensus versus the leadership decisions, those kinds of things all really help determine whether a structural solution, delivers the most cost benefit in a cost benefit sense over the life cycle of the building, or whether a neutral environment with tons of data, air, electrical capacity that can be whatever it needs to be on a day-to-day basis delivers the most capacity for you as an organization. So to me, it's about really getting at what's of value to you, because you can't afford it all. This utopian flexibility in the building is sure it's theoretically possible, but what that means and what you sacrifice to get it is you're probably not going to take up all that flexibility, so it's not really of value to you, right. And you'll give up something pretty important along the way.
Mark?
I just, counterpoint here. One of our clients has a 100-year-old building that they're moving out of, and they're looking at the next building being a 100-year building as well. Mm-hmm. So, we know we talked 50 years and all that, but it could be 100 years. Sure. And you've got no idea what's going to be happening in 100 years, right? Right? Penicillin wasn't commercially available until like 1945. 100 years ago, we just barely had lights inside of the operating room. We had it on the top floor so that we could have glass, shining in there, right? And I've seen that operating room. It's fascinating to look at. So we have no clue. So focus on purpose-built. Focus on immediate objectives, right? And one of our immediate objectives, and we've all agreed about this, is the virtualization of the healthcare system. Mm-hmm. So let's look at our facilities and say, how can that facilitate collaboration, communication outside of the four walls? How can I make it such that when a doctor's doing rounding, not only are they rounding on patients inside of that ward, but they're also doing it virtually and able to seamlessly transition to that virtual patient as part of their rounding process, so that nurse is watching people virtually as well and leveraging and providing hospital at home and other types of capabilities. Find your purpose, find your immediate purpose, and build it out to achieve that, and who knows what tomorrow brings.
But I think that's really the challenge. What is the purpose? And I think that's something that people are redefining constantly. So creating a purpose-built environment when you're not really sure what you're trying to do in it is pretty significant as a challenge. So I think you have to have those conversations to test the waters and decide what the purpose is for them. Because for some organizations, and tertiary quaternary care academic centers particularly, their purpose might be that constant change, that innovation, that ability to test and explore. For others, their purpose may be stability, familiarity. This is the base from which we do all those other things. I think finding that purpose is really the challenge for a lot of organizations.
So I want to say thank you to all the panelists, and I'm going to ask you one last question. We have heard a lot of good ideas. If you were sitting here 10 years from now and looking back and saying the future has arrived, what would have become real out of all the ideas that we have shared with the audience? What would have become real? I mean, I know we talked about technology and architecture and patient experience. Are we predicting something that is going to happen way in the future, or will it be here in 10 years? And what will that be?
I guess the question in all this for me is, does any of this improve the outcome of the patient?
Yeah.
So I think you have to, everything can't be everything, but I think you have to say that some parts of your hospital, the center hospital, the quaternary care place, has this high-tech diagnostic platform that is flexible. That has to happen. And then I think you have to look at the whole continuum, and I think home care will increase, and probably protocols that can be done outside the hospital, and ambulatory care will continue to get more saturation. So I think there's a move away from, you need the main center, but it's the community that's going to have a lot of other things, and that's what I think is going to happen.
Rueben?
Yeah, so we had that opportunity to see that Kaiser presentation, and they thought they had a great facility. And we laughed at it because of what they did. I'm sure, and we've got some videos of our current place that is 10 days old. 50 years from now, I think people will do the same because of what technology has done. And so I think 10 years from now, we'll see a lot of different things. And so some of the discussion was, how do you accommodate the building for bigger equipment that's coming along? I think one of our challenges, how do we accommodate for smaller equipment that's coming along, and how do we change the delivery of healthcare? So the super Fitbits, and maybe every patient's going to have a super Fitbit when they come in, and they're going to do their vital signs, and that's going to be triggered. We're probably going to. Barb wants the Captain Kirk chair with the wall that we monitor all the patients. And so not only the patients that are in the hospital, but the patients that are connected to our facility that need monitoring and get to that health care without walls. And so the miniaturization, as we've seen in ultrasound, is critical to what's going to happen. I think that's what you're going to see. And I think this is only the infancy of what's the future to bring.
So with that, I want to close the discussion, and thank you, everyone. Appreciate it, and thank you.